And this is an article published in 2019. We have taken from Journal of Autoimmune Disorders, basically which says whenever the mother has autoimmune disorder, she is at the increased risk of preterm birth. That's what this article says. Uh, and so we would like to present an interesting case of a neonate born to mixed connective tissue disorder. So basically, she was a G2P1D1 mother diagnosed with rheumatoid arthritis 6 years back. Later, she had hypothyroidism, ILD with pulmonary hypertension. Renal biopsy was suggestive of lupus podocytopathy, diagnosed as MCTD, mixed connective tissue disorder, and she was on multiple medication for the same. G1 was severe preeclampsia. It was a vaginal delivery, 700-gram baby. It was a neonatal death elsewhere. Exact details we don't know. And G2 was diagnosed with PH at 28 weeks. Again, she was on a couple of medications for the same. And she underwent emergency LSS at 31 weeks in view of absent end diastolic flow in the umbilical artery. So post-delivery, so baby's weight was low birth weight, and baby received RDS. For the RDS, baby received NIV support, CPAP support, and which did not require the surfactant. Had a severe metabolic acidosis, however, it resolved over a period of time. Had feed intolerance, gastroparesis, which improved with prokinetics and domperidone, erythromycin, and other things. So the biggest the drawback is the baby had grade 3 PVL, so which we noted on third week scan, so which was attributed to the autoimmune disorders in the mother. This is another interesting case. So where case of a neonate born to mother with SLE. She was a 32-year-old lady, G2P1L1 mother with a SLE, with PAH, with hypothyroidism. Mother had hyperthyroidism at 20 years, could be Graves, managed with the medications long back. And she was diagnosed with SLE 7 years back, had alopecia, joint pain, photosensitivity, oral ulcers, and ANA positive, and treated with HCQ for the same. This was IVF conception. So initially managed for a threatened abortion, managed conservatively, and treated with hydrocortisone and prednisolone. And at 24 weeks, she had a PIH managed with labetalol, nicardipine, and hydralazine. Again, she underwent emergency LSS in view of Doppler changes. It was a 28-week baby with a birth weight of 900 gram with IUGR features. Baby required support for RDS, and baby had early onset thrombocytopenia, which resolved over a period of time. And the main thing here is baby had conjugated hyperbilirubinemia from the day 7 of life, so which gradually improved over a period of 2 months. So this again was attributed to the autoimmune thing in the mother. So coming to the diagnosis of neonatal lupus, basically it requires two things. The one is the presence of antibodies, either SSA or SSB or a RNP antibodies. Second thing is the classic clinical feature. Either it can be a typical rash or a hepatic involvement in terms of raised liver enzymes or hematological manifestations like thrombocytopenia, or it could be anemia. And to rule out other causes. And these are the various effects on the baby. So whenever the mother has SLE or any other autoimmune rheumatological disorder, when she has SSA antibodies are present, basically two things we can expect here. One is the short-term consequences that includes neonatal classic lupus rash, and the second thing is hematological manifestations, as I mentioned earlier, and the hepatic things. These are transient and reversible. However, the another thing is the long-term consequences. This includes congenital heart block, so which accounts for about 1 to 2%. The main thing here is this is a permanent and it's irreversible. This is the catch here. And this is a beautiful diagram. This is explained about so what happens when the mother has a SSA or a SSB antibodies basically in the womb. Two theories holds good here. One is apoptosis theory, and the second one is calcium channel theory. What happens in apoptosis theory is basically there will be a transfer of SSA or SSB antibodies into the mother. This will attack the fetal myocardial cells, whenever there is a damage, as expected, there will be inflammation, and post that there will be a fibrosis. So whenever there is a fibrosis, it will affect the conduction system. In these, they are more prone for arrhythmias, number one. And number two, the other theory, what they explain is calcium channel theory. So basically, these antibodies block the calcium channels, basically L type and T type. This will lead to either the first degree heart block, or a second degree, or a third degree heart block. So ultimately, cumulatively, net outcome is long-term consequences, which includes either a permanent AV block, number two, long QT syndrome, number three, ventricular arrhythmias. And this is another case which we would like to uh, present today. It was a case, neonate born to a mother with SSA antibody positive. She was a primary spontaneous conception, antenatally referred at 22 weeks in view of fetal bradycardia. Mother was positive for SSA antibodies, started on steroids from the second trimester. Scan at 27 weeks showed complete heart block. Had a PPRM, delivered a late preterm. It was a 35-week plus 4 days baby with a birth weight of 1.43, so which was again IUGR. So baby was fine except for the isolated cardiac involvement. Respiratory was baby was fine. We noted that no cutaneous manifestations were there. LFT was fine. RFT was fine. No hematological involvement. Isolated cardiac involvement was there. So which required a prolonged respiratory support. And ECG, you can see the complete heart block here. So going further, echo showed suggestive of bradycardia, good biventricular function with a small PDA and no pericardial effusion. This baby was managed conservatively. Target heart rate was above 55. Baby had a low heart rate because of complete heart block and started on orsiprenolin as heart rate was below 55. Discharged on orsiprenolin with a low flow oxygen support and tube feeds. Currently, baby is 4 months around with off oxygen on oral full feeds and gaining weight. So further plan to place a cardiac pacemaker once the baby has gained adequate weight. That is around somewhere around 2.5 to 2.8 kg. And this is another interesting case where the mother was positive for SSA antibody. So it was a preterm 32-week plus 2 days. It was a male 1.7 outborn. Maternal history, she was a G2A1 mother with a known case of Sjogren syndrome. G1 was an abortion for a fetal bradycardia. Mother was positive for SSA antibodies. She was on HCQ and dexamethasone for the same. She had underwent emergency LSS in view of fetal bradycardia and oligohydramnios. So postnatally, baby was referred to our unit in view of persistent bradycardia. So again, this baby had a respiratory distress managed on CPAP. Uh, Post respiratory distress, once the distress settled, we can see what we can see is isolated cardiac involvement was there. Heart rate around 70 to 75. ECG showed complete heart block. 2D echo otherwise normal structurally. This was baby started on IV isoprenalin, later changed to oral. Discharged with a plan to put a permanent pacemaker and follow. So coming to the antenatal management of a mother with a anti-SSA antibody. So what to do is whenever the mother comes or a pregnant woman with a autoimmunity with either SSA or SSB antibodies comes, I obviously we expect some complications in the form of either a congenital heart block or a dilated cardiomyopathy or a endocardial fibroelastosis. Based on the available literature, what we can say is the maternal HCQ protects from the congenital heart block, number one. And serial fetal echocardiography has been advised from the 17th week. And again, further to carry with the fetal echocardiography based on the either weekly or a bi-weekly, depending upon the clinical situation. And what to look for a prolonged PR to suggest the first degree or a second degree heart block. And consider dexamethasone to prevent the further progression or IVIG after the diagnosis of fetal block. And when the heart rate is below 50 or 55, we can use maternal sympathomimetics. So this is a beautiful diagram. So basically it is showing how to manage antenatal mothers with autoimmunity with SSA or SSB antibody positive. So it needs a multidisciplinary approach. Basically involve rheumatologist along with obstetricians and fetal medicine specialist, NICU consultants and pediatric cardiologist. The idea is to monitor somewhere start around 17 week of gestation. Monitor for the fetal echoes in the to look for fetal bradycardia. Basically, they look for PR interval. PR interval anything 150 and above. Consider dexamethasone 4 mg daily. Look for the progression depending upon the clinical condition. How early to do echo, that depends on each case. And whenever you see second degree or third degree progression, consider IVIG also along with the dexamethasone. And when the heart rate is below 50 or 55, third degree heart block is there. Along with IVIG, DEXA, we can consider beta sympathomimetic also. And severe third degree heart block with severe air drops, evidence of myocarditis or a myopathy, effective endocardial fibroelastosis, back to the parents and give them the option. And we can consider termination also. That is one more option after discussing with the parents. And when to delivery, again the question. Elective delivery at 36 to 37 week in a specialized center where the multidisciplinary team is available, especially our cardiac team is good and NICU care is good, number one. And when to deliver early, if eye drops is there or ventricular ectopy is there, reduced shortening fraction or any AV valve regurgitation is there, consider delivering early. And again, the one more, the gray area is whenever the fetal heart block is there. So to monitor the FHR, it will become a difficult situation. Again, to interpret fetal bradycardia or either because of distress or because of congenital heart block, it will become a difficult part here. And these are the little commonly used drugs during the pregnancy and the lactation. And you can see the drugs includes hydroxychloroquine, steroids, calcineurin inhibitors, sulfasalazine. All the drugs carries the low risk for teratogenicity, number one. And all the drugs are compatible with the lactation. And few complications with the steroids, as expected, increased risk of hypertension, preeclampsia, higher sugars, preterm, PRM, and IUGR. With a calcineurin inhibitor, there is an increased risk of preterm birth and IUGR, and that should be counseled to the parents. So coming to the postnatal management of lupus, optimize the acid-base status, provide a respiratory and circulatory support, and monitor ECG, look for first degree heart block, second degree heart block, look for the progression if the heart block is there. And whenever the heart rate goes below 55, involve the cardiac team and plan accordingly for the cardiac pacemaker. And other thing is, retrospectively, if any baby has a heart block in the absence of structural abnormalities, always look back that the mother, whether she has a SLA or not. And this is about pacemakers. Almost 70% of the kids with a congenital heart block by the age of 1 year needs pacemaker in one or other way, especially with a third degree heart block. Pacemakers includes either epicardial pacemaker or a transvenous pacemaker. And the various factors affecting the success of pacing includes the prematurity, the lower the gestation, very difficult to put a pacemaker. And again, the low birth weight, difficult to put a pacemaker. Poor hemodynamic status, metabolic acidosis, these are the certain factors which will affect the success of pacing. So coming to the outcome, so whenever the mother has autoimmune, which is complicated in the pregnancy, she has a SSA antibodies present, what to expect in the baby? So how to counsel them? So for that, we should know the risk of congenital heart block, that is 1 to 2%. And the risk increases to 30% if the previous baby had a congenital heart block. And the morbidity, mortality is around 15 to 30% with CHB. And as I said earlier, the need for the permanent pacemaker will be about 47 to somewhere around 70%. And again, this is interesting. No risk to the fetus if the maternal antibody levels are below 50. So coming to the outcomes of pacemaker, there are short-term consequences, long-term consequences. Short-term include left ventricular dysynchrony, sorry, especially in the right ventricular leads, LV dysfunction, and the valvular regurgitation. Long-term consequences includes high risk for cardiovascular morbidity and infections, increased prevalence of autoimmune channelopathy, and earlier onset diastolic dysfunction. And this about how to tackle the mother. So whenever she had anti-SSA, the prior pregnancy is had some complication, how to go it further. So to know that there are some risk factors for developing CHB, so which includes the presence of SSA or SSB antibodies, as I told earlier, and the higher titers of SSA, previous baby with CHB, congenital heart block, cutaneous lupus in a sibling, and lack of prophylactic treatment with the HCQ. So what we can do? So from our side, we can closely monitor starting from the 17 week, as I said earlier, and to start the prophylactic treatment with the HCQ. The dose is 400 to 800 mg once a day. When to start? Again, somewhere between 6 and 10 week of gestation. So coming to take-home message, the take-home message here is have a high index of suspicion. Mother with the autoimmune disease is prone for various complications, either because of autoimmune disease per se itself or because of drugs, which include severe PAH, preeclampsia, which might require multiple medications. And always when the mother is there, such mothers are there, try to refer them early with a center where the multidisciplinary team is available, and the key is involvement of multidisciplinary team and the early starting of SCQ. And these are the red flag signs in a mother with anti-SSA antibodies. This is useful whenever we are counseling an antenatal mother. Suppose some mother comes with a autoimmunity with SSB or SSA antibodies with a congenital heart block. This we can look for the red flag signs. Red flag signs particularly includes earlier occurrence of CHP carries a bad prognosis. Again, the presence of eye drops, bad prognosis. Lower heart rate at the presentation carries a bad prognosis. Endocardial fibroelastosis, dilated cardiomyopathy with valvular regurgitation or valvular dysfunction, male sex, delivery below 34 weeks carries a higher mortality and morbidity. And this is we oftenly see 2 to 3 cases in a month we see with rheumatological diseases. This was a recent case we thought we'll discuss, we'll share with you people. So it was a 37-week 2.58 kg baby, so born to G4A3 mother. She was a known case of Sjogren's syndrome with ANA, SSA and SSB positive. Mother had received dexamethasone, IVIG and SCQ in the antenatal period, and antenatal echo was showing endocardial fibroelastosis. Postnatally, baby transition was uneventful. Baby cried after birth, and postnatal echo confirmed endocardial fibroelastosis. Baby received 2 gram per kg of IVIG for the same. Currently, baby is 2 months. We are closely following up, and baby is doing fine. And this about the reference article I have put here, which demonstrated the promising clinical results following the IVIG and steroids in EFE without conduction abnormalities. So, so coming to the last slide, this was a antenatal case. So this I would like to everyone to participate in this case. This was an antenatal case which our obstetric team told us to counsel. The history was like this. It was a 32-year-old primary mother admitted at 24 week of gestation. She was admitted on December 12th, 2023 for fetal bradycardia. Mother was positive for SSA antibodies and received hydroxychloroquine, prednisolone, and enoxaparin for the same. 2D echo was suggestive of third-degree heart block with heart rate, ventricular rate around 55 beats per minute with endocardial fibroelastosis. Mother has received IVIG 60 grams and advised to continue SCQ, dexamethasone 4 mg, and with enoxaparin. So neonatal team was asked for antenatal counseling. I request the members to go ahead and put their valuable opinions regarding the case.
Thank you, Rangnath, for a wonderful presentation. This is a very classical situation, the case you have put up just now last. Now, it's a periviable baby at 24 weeks. They're very keen. This was, in fact, I remember it was an IVF pregnancy, and they had no chances of having another pregnancy. They're very keen for treating the baby. But then you see the baby already has congenital heart block with a heart rate of 55. So I just want anybody can unmute themselves and just suggest what could be the course of action they'll suggest for the obstetric team to continue with. Anybody?
Any thoughts what we can counsel them? I have told about the red flag signs. This baby has all the red flag signs, and she is a 24-weeker mother. Just your valuable thoughts.
I can see 2, 3 people have unmuted themselves. Would you like to talk? Anybody? No. Okay. So anyway, this is Dr. Rohit has said you watch for hydrops and echo, terminate if required, if it occurs. Well, you see, this child is very precious, and parents didn't want to probably go for that option. They still wanted to see. So again, I would say in a center like ours, which is looking after periviable babies quite frequently, we said that probably if this child didn't have a third degree block, this outcome would have been 50% chance of good survival, even without any long-term morbidity in another 50%. But as Dr. Vipul has said, yes, you are absolutely right. The third degree heart block further worsens the prognosis, with the periviability itself creating so much issues with requirements for ventilation and so much long-term care. The third degree out, so really that was a big challenge. And even if the child had delivered, we would not have been able to offer any surgical intervention like a pacemaker. We would have at the most said that we can try some drugs like orsiprenylene and see what happens. But we would have definitely not been able to predict the hemodynamic outcome of this baby, and this child would have had a higher chance of mortality. So, like another gentleman has suggested sympathomimetic in the mother. In fact, you're right. It has been started, but not at that juncture. Recently, this mother has been started. So, as Dr. Rangnath will tell you now, Rangnath, can you just see? Yeah, we have suggested to continue the pregnancy as much as is possible, and therefore we ask them to continue as much as possible, continue the pregnancy, and we'll see what happens. Now the child is about, the mother is about 30 weeks or maybe 31 weeks, I think. And well, recently, well, the outcome looks better and the weight is also catching up. So I think now the mother is, and the obstetrician is more confident. So they have started some sympathomimetic for the mother as well. So this is going to be a challenge. All of you are budding young neonatologists who are going to come out into the profession as consultants very soon. And you will be asked all the time, especially if you are doing a 3-year DM or a DNB neonatology program, you're going to become consultants in high-risk tertiary care centers, referral centers. And as mothers are getting filtered, all the filtered out seriously morbid mothers may come to you for assessment and for treatment in the high-risk perinatal center. So this is a large group of patients which have rheumatological disorders. As it is, these disorders are being picked up more by our rheumatological and medicine consultants, and pregnancies are happening, though earlier days SLEs and Sjogren's syndrome, they will remain infertile, but nowadays with more of artificial reproductive techniques, these mothers are getting pregnant and they are being well monitored and managed during pregnancy. So there will be a definite fallout of us having to give opinion and look after these babies much more aggressively. So this is going to be the future, and I'm sure all of you agree that this is being seen by many of you more and more, at least in high-risk tertiary care centers. So any other comments or questions are there, please? Rangnath, would you like to say anything?
That's it, sir. Thank you for the valuable input. As you said, the frequent monitoring and the risk assessment and MDT team involvement becomes necessary here. So that's it from my side, sir. Any questions from anybody, you can ask us.
So these kind of babies are usually very unwell at birth, and they are likely to be preterm, growth retarded, as Dr. Rangnath mentioned, hematologically afflicted. They may have cardiac complications. So these babies have always been a great challenge for us, even in higher centers, to manage. So if the incidence of rheumatological disorders, which I believe is also increasing, our rheumatologists mentioned that rheumatological disorders themselves are increasing, and particularly so in women. And these women carrying such a high-risk pregnancy becomes a great challenge for all of us. So Vipul has asked, what are the drugs post-delivery for heart block? I think Rangnath, you want to answer that?
Sir, like uh, we can try sympathomimetics, like salbutamol is there, and again the various articles suggest about use of atropine, and depends if you're thinking in terms of congenital heart block. Again, we have a sympathomimetics, few drugs in that salbutamol, isoprenaline, orciprenaline, or atropine. And again, for other thing like endocardial fibroelastosis, recent article has come in 2019, which has demonstrated the effectiveness of IVIG and the steroids. One case I was seeing where it was a case of a third degree heart block. They followed up to 8 years, and the baby was on a couple of doses of IVIG and received a long-term steroids. The good thing about this baby was eventually, so it was reverted of third degree heart block. That was a good thing here. So depends on the case actually. So what we are looking at, and what is this one?
I may just add on to this. This last 1 year, we have had 3 or 4 children with congenital heart block. Luckily, all of them have done well with just orciprenaline orally and they're at home. Unfortunately, many of them still have not been able to reach the weight conducive enough for a permanent pacemaker. Permanent pacemaker, there was a brand which was available till last year, which was able to be inserted in a child as small as 2.5 kilo, but that's gone out of the market in India. So we are waiting for these children to get the right size of pacemaker so that they can be inserted. So otherwise, by God's grace, they have remained hemodynamically very stable, and they have not required anything more than orciprenaline. So luckily for us, that has happened. And this other baby with the endocardial fibroelastosis, Dr. Rangnath mentioned, who we anticipated will be very sick, has turned out to be quite stable. Though I think the IVIG has probably helped. Soon as the baby was delivered, we gave that. Rangnath, do you remember the dose of orciprenaline?
No, sir, I should go
I'm
to the
having to ask
literature.
you.
I'll get back the dose because I don't remember now.
Orciprenaline is a standard dose. Unfortunately, we always refer to a drug dosages book for that. But if you go back on the slides, can you see what we mentioned the dose of
No, sir,
orciprenaline
we have
in the
not mentioned.
slides?
I have not mentioned. Maybe around roughly around 0.01 something is there, but I'm not sure. I'll get back, sir. I'm not sure about that. So I
It's
have
a standard dose. It's not anything
stand.
unusual. It's a standard dose. Yeah. Great. So if any other questions are there, one last time I'll just
Uh,
ask anybody else. Yeah.
any studies in the babies regarding this long-term neurological outcome? I tried searching, but I couldn't get the studies as such, the long-term neurological outcome. Again, the long-term neurological outcome depends on many factors, like when the baby delivered, either it was a delivered extreme preterm or close to the late preterm. So various factors, but however, I couldn't find any the articles the pertaining to the question. Any other questions from anyone?
Fine. In that case, we'll just probably close this session. It was a very kind of a unique opportunity for us to share these cases because more and more we are seeing these kind of children now. And we see these kind of mothers and pregnancies are likely to be afflicted with severe morbidity from the mothers themselves and as well as in the baby. So we thought it's very appropriate to share this. So thank you so much, all of you. It was wonderful having you again in this session. We look forward to having more sessions with all of you.
Thank you, sir. Thank you so much, sir.
Thank you, Rangnath, for a great presentation.
Thank you, sir. Thank you. Thank you, sir. Good night, everybody.